something is quietly happening inside your joints right now. Not the pain you already know about. Not the stiffness that greets you in the morning or the ache that follows you up the stairs. Something deeper. Something at the cellular level inside the cartilage, inside the synovial membrane, inside the molecular machinery of your immune system, that is either protecting your joints or failing to protect them, depending on a single number that most people with arthritis have never been told to check. That number is your vitamin D level. And the reason I am starting this video with that statement is not because vitamin D is a miracle cure for arthritis. It is not. But the research that has accumulated over the past 2 decades on the relationship between vitamin D and osteoarthritis and joint pain is specific enough, consistent enough, and mechanistically well understood enough that every single person managing arthritis deserves to understand it and to know whether their own vitamin D level is in the range that the science associates with joint protection, or in the range that the science associates with accelerated joint damage. Today I am going to tell you what that science says. I am going to explain exactly what vitamin D does inside your joints, not in general terms, but specifically at the level of the cells and the molecules that determine whether your cartilage is maintained or destroyed. I am going to tell you what the clinical trials show about vitamin D supplementation and arthritis outcomes. And I am going to give you the specific, practical information about dose, form, and target levels that most people with arthritis have never received. This video could change something real about how you manage your arthritis. Because for a significant proportion of people watching right now, a simple blood test and a low-cost daily supplement could be one of the most effective interventions they have not yet tried. If that sounds like something you want to understand, subscribe to this channel right now before we go any further. Every week we publish evidence-based content specifically designed for adults managing arthritis and joint pain who want real science explained clearly. Hit subscribe. Let us get into this. Now, before we talk about what vitamin D does in the joint specifically, let us talk about why almost everyone with arthritis is deficient in it. Because the deficiency itself is the context that makes everything else in this video make sense. Vitamin D is not simply a vitamin in the traditional sense. It is more accurately described as a steroid hormone, a fat-soluble compound that, once converted to its active form in the body, circulates through the bloodstream and binds to receptors expressed on cells throughout the body to regulate gene expression. Unlike most vitamins that must be obtained entirely from diet, vitamin D can be synthesized in the skin from ultraviolet B radiation, which is why it is sometimes called the sunshine vitamin. But this synthesis pathway fails in the majority of adults over 50 for reasons that compound with each decade of aging. The first failure point is the skin itself. The concentration of the vitamin D precursor compound 7-dehydrocholesterol in the skin declines significantly with age, reducing the synthesis capacity that sun exposure can activate. Research has documented that a 70-year-old produces approximately 25% of the vitamin D from the same sun exposure that a 20-year-old would produce, meaning that the outdoor time that adequately maintain vitamin D levels at 30 is genuinely insufficient to do the same job at 65, even in sunny climates. The second failure point is the conversion pathway. The vitamin D produced in the skin or consumed in food is not biologically active. It must be converted first in the liver to 25-hydroxyvitamin D, the storage form measured in blood tests, and then in the kidneys to calcitriol, the fully active hormonal form. Both of these conversion steps become less efficient with age. The kidney's capacity to perform the final activation step declines progressively from middle age onward, meaning that even when the storage form is adequate, the active hormonal form may be insufficient in older adults with reduced kidney function. The third failure point is diet. Vitamin D is present in meaningful amounts in very few foods: fatty fish, cod liver oil, egg yolks, and vitamin D fortified dairy products. The portion sizes needed to maintain adequate vitamin D levels through diet alone are impractical for most older adults. The average American diet provides approximately 100 to 200 international units of vitamin D per day, a fraction of the daily requirement for adults over 60. The result of these three compounding failure points is that vitamin D deficiency, defined as a serum 25-hydroxyvitamin D level below 20 nanograms per milliliter, affects approximately 40% of American adults. In adults over 60 specifically, the prevalence of deficiency and insufficiency combined approaches 70% in some population studies, meaning that the majority of older adults with arthritis are managing their condition in a state of vitamin D inadequacy that the research increasingly suggests is actively worsening their joint outcomes. The seasonal variation in vitamin D levels is a practically important dimension of the deficiency story that most people have never thought through systematically. Vitamin D levels naturally peak at the end of summer, after months of skin synthesis from sun exposure, and decline progressively through autumn and winter as sun angle decreases and exposure time falls. In northern latitudes above approximately 35 degrees north, which includes most of the continental United States, the ultraviolet B radiation needed to synthesize vitamin D in the skin is insufficient from approximately November through March, regardless of how much time is spent outdoors. Adults who test their vitamin D level in summer, when levels are at their annual peak, may receive a reassuringly normal result that does not reflect the significantly lower levels they will experience through the winter months. Testing in late winter, February or March, before the new sun season begins, captures the true nature of the annual vitamin D cycle and provides the most accurate picture of whether supplementation is achieving year-round adequacy. Year-round supplementation rather than sun-dependent maintenance is the appropriate strategy for adults with arthritis in most North American latitudes. The body weight dimension of vitamin D dosing is equally practically relevant. Vitamin D is a fat-soluble compound that distributes into adipose tissue and is sequestered there rather than remaining in circulation. Adults with higher body fat volume require higher vitamin D doses to achieve the same serum level as lighter adults, because a greater proportion of each dose is partitioned into fat stores. Research has consistently documented that adults with obesity require approximately 2 to 3 times the vitamin D dose of normal weight adults to achieve equivalent serum levels, meaning that the standard recommended supplementation doses may be insufficient for many adults over 60 managing arthritis alongside overweight or obesity. Now let us talk about what is happening inside the joint when vitamin D is deficient, because this is where the science gets specific. And specific is what makes this information actionable. The joint contains multiple cell types that express the vitamin D receptor. VD are the molecular switch that vitamin D activates to regulate gene expression. Chondrocytes, the cells that maintain the cartilage matrix, express BD are throughout the articular cartilage. The cells lining the synovial membrane express VDR and respond to vitamin D signaling. Macrophages, the immune cells that infiltrate the synovial membrane and produce the inflammatory cytokines that drive joint damage, express VDR in particularly high density. When calcitriol, the active vitamin D hormone, binds to VDR in chondrocytes, it activates a set of gene expression changes that collectively represent a protective program for the cartilage matrix. It suppresses the production of matrix metalloproteinases, the enzymes that degrade the collagen and aggrecan of the cartilage matrix when activated by inflammatory signals. It promotes the synthesis of the cartilage matrix components that the chondrocytes are responsible for maintaining, and it suppresses the production of inflammatory cytokines by the chondrocytes themselves. When vitamin D is deficient and calcitriol is insufficiently available, these VDR-mediated protective programs are silenced. The matrix metalloproteinases that degrade cartilage go unchecked. The inflammatory cytokine production by chondrocytes and synoviocytes is amplified, and the cartilage matrix deteriorates faster than the chondrocytes can repair it, producing the progressive cartilage thinning that is the hallmark of osteoarthritis progression. The immune dimension of vitamin D's role in joint health is equally important. Vitamin D exerts powerful immunomodulatory effects through its VDR-mediated actions in immune cells. It suppresses the differentiation of naive T cells into Th17 cells, the pro-inflammatory immune subset that drives the autoimmune attack on synovial tissue in rheumatoid arthritis and contributes to the inflammatory environment of severe osteoarthritis. Simultaneously, vitamin D promotes the expansion and function of regulatory T cells, the immune subset that suppresses excessive inflammatory responses and maintains immune tolerance. This shift from Th17 dominance toward regulatory T cell balance is, at the molecular level, an anti-inflammatory shift that reduces the inflammatory load on the joint. Research published in the journal Autoimmunity Reviews documented that vitamin D deficiency was significantly associated with higher disease activity in rheumatoid arthritis, with lower regulatory T cell numbers, and with higher serum concentrations of the inflammatory cytokines interleukin-17 and tumor necrosis factor alpha. And when vitamin D levels were restored through supplementation, disease activity scores improved, regulatory T cell numbers increased, and inflammatory biomarker levels declined, providing a mechanistic chain of evidence from molecular biology to clinical outcome that is rarely this complete in nutritional research. Here is your pause. I want you to stop for a moment and ask yourself one question. When did you last have your vitamin D level checked? Not your calcium, not your bone density, your vitamin D, the 25-hydroxyvitamin D blood test. If the answer is never or more than a year ago, or you are not sure, drop a comment below right now and tell us. because this one test could be the most important piece of missing information in your current arthritis management. And knowing where you stand is the first step toward doing something about it. We read every comment. Let us talk about the clinical trial evidence because mechanism is compelling. But what adults with arthritis need to know is whether vitamin D supplementation actually produces measurable improvements in pain and joint function in real patients. A study published in the journal Annals of the Rheumatic Diseases followed adults over 50 for several years and found that those in the lowest vitamin D quartile showed significantly greater cartilage volume loss on MRI and significantly higher rates of radiographic osteoarthritis progression compared to those in the highest quartile, independent of age, body weight, and physical activity level. A meta-analysis published in the European Journal of Clinical Nutrition pooled data from multiple randomized, controlled trials of vitamin D supplementation in knee osteoarthritis and found significant reductions in pain scores and significant improvements in physical function across the combined patient population. The clinical trials have also revealed an important nuance. The benefits of vitamin D supplementation are most pronounced in patients who were deficient or insufficient at baseline, and who achieved adequate vitamin D levels through supplementation. Trials that enrolled patients without first verifying their baseline vitamin D status found smaller average effects because deficient and already adequate patients were mixed together. The practical lesson: the question is not simply whether to supplement but whether you are deficient, which is why the baseline blood test is the essential first step. Now let us be precise about what adequacy means, because the definition your laboratory report uses may not be the definition the arthritis research supports. The standard clinical laboratory cutoffs define vitamin D deficiency as below 20 nanograms per milliliter and insufficiency as between 20 and 30 nanograms per milliliter. These thresholds were established primarily in the context of bone health and represent the floor below which frank skeletal disease emerges. The arthritis research uses a different and higher threshold. Multiple studies have found that the joint protective effects of vitamin D are most consistently observed at levels above 30 nanograms per milliliter, and that the optimal range for musculoskeletal health, including the VD-mediated cartilage protection and immune modulation we have described, is between 40 and 60 nanograms per milliliter. This gap between the laboratory's normal range starting at 20 and the arthritis research's optimal range starting at 40 is clinically significant. An adult with a vitamin D level of 25 nanograms per milliliter will receive a laboratory report that says normal. But according to the arthritis research, that level is insufficient for the joint protective functions that vitamin D is supposed to be performing. The conversation about vitamin D and arthritis would be incomplete without addressing why this is not routinely tested and supplemented as a standard component of arthritis care. The answer is partly historical. The vitamin D and arthritis research has matured significantly over the past 15 years, and older clinical guidelines were established before this research base was fully developed. It is partly structural. The clinical appointment does not naturally accommodate the detailed nutritional conversation that the vitamin D evidence deserves. The result is that millions of adults with arthritis are managing their condition without knowing their vitamin D level, without understanding its relevance to their joint health, and without the specific supplementation that would address a deficiency linked by the research to worse outcomes. This is a gap that informed patients can close for themselves by requesting the specific test and discussing the specific supplementation protocol with their physician. The test itself, a serum 25-hydroxyvitamin D level, is a standard blood test available at any clinical laboratory, covered by most insurance plans, when ordered with a clinical indication such as arthritis, and requires nothing more than a routine blood draw. For adults who prefer to monitor their levels at home, mail-in vitamin D testing kits are available from several laboratories that provide clinically valid results from a fingerstick blood sample at a cost of approximately $50 to $80. The practical protocol for vitamin D supplementation in adults with arthritis. The form, vitamin D3 cholecalciferol, is the correct form. Vitamin D2 ergocalciferol raises serum vitamin D levels significantly less efficiently than D3 and is not the form used in the clinical trials that generated the evidence we have described. When purchasing a supplement, verify that the label says D3 specifically. The dose, for adults who are deficient below 20 nanograms per milliliter, 2,000 to 4,000 international units per day, are typically needed to reach the optimal range. For adults who are insufficient, between 20 and 30 nanograms per milliliter, 1,000 to 2,000 international units per day is typically sufficient. For adults maintaining optimal levels, 1,000 to 2,000 international units per day is appropriate maintenance dosing. The timing: vitamin D is fat-soluble and is absorbed most efficiently when taken with a meal containing dietary fat. Taking your vitamin D supplement with breakfast or with the most fat-containing meal of your day maximizes absorption from each dose. The monitoring, vitamin D levels, should be retested approximately 3 months after initiating or changing supplementation to verify that the target range of 40 to 60 nanograms per milliliter has been reached. The follow-up protocol is straightforward: retest at 3 months, confirm target range, maintain. If your level has risen, but not yet reached 40, discuss a dose increase with your physician. This testing and titration approach is how the clinical trials that generated the arthritis evidence were conducted, and it is the approach that gives every adult with arthritis the best possible chance of receiving the joint protective benefit the research supports. The safety profile of vitamin D3 at these doses is excellent. Vitamin D toxicity is extraordinarily rare at doses below 4,000 international units per day, and essentially unheard of at doses below 10,000 international units per day. The risk of remaining deficient with the documented joint protective functions of vitamin D unperformed substantially outweighs the theoretical toxicity risk at standard supplementation doses. The integration of vitamin D with the other proven arthritis compounds we discussed in our previous video, omega-3 fatty acids and vitamin K2 with its matrix GLA protein carboxylation mechanism, creates a comprehensive daily nutritional strategy that addresses inflammatory regulation, resolution signaling, and structural joint protection simultaneously. Vitamin D does not work as a standalone miracle for arthritis, but as one pillar of a comprehensive, evidence-based approach alongside the anti-inflammatory dietary strategies, the daily exercise program, and the medication management principles we have covered across this series. Vitamin D is perhaps the most immediately actionable intervention available. Because unlike the dietary changes that require restructuring daily eating habits, unlike the exercise program that requires building a new daily routine, the vitamin D intervention requires only 2 things: a blood test to find out where you stand, and a daily capsule if you need it. 1 test, 1 conversation with your physician, 1 daily capsule. The simplest intervention in this entire arthritis series, and possibly the most impactful one you have not yet made. Your joints have been asking for this. The research has been building this case for 20 years. And now you have the information to act on it. The relationship between vitamin D and pain beyond the joint-specific mechanisms we have described deserves specific discussion because it reveals a dimension of vitamin D's relevance to arthritis that most people have not encountered, and that has direct practical implications for the daily experience of living with chronic joint pain. Vitamin D receptors are expressed not only in joint tissues, but in the pain processing pathways of the nervous system, specifically in the dorsal root ganglia, where the sensory nerve cell bodies that transmit pain signals from peripheral tissues to the spinal cord reside, and in the dorsal horn of the spinal cord, where incoming pain signals are amplified or modulated before being transmitted to higher brain centers. Vitamin D signaling in these neural structures influences the production of nerve growth factor, a compound that sensitizes pain fibers and lowers their activation threshold and modulates the calcium channel activity that determines how readily pain neurons fire in response to peripheral stimulation. Research has documented that adults with chronic pain conditions, including chronic musculoskeletal pain, fibromyalgia, and chronic low back pain, have significantly higher rates of vitamin D deficiency than the general population, and that vitamin D supplementation in deficient individuals with chronic pain produces meaningful reductions in pain scores, even in the absence of the specific joint pathology of osteoarthritis or rheumatoid arthritis. A systematic review published in the journal Pain Medicine found that vitamin D deficiency was significantly associated with chronic musculoskeletal pain across multiple study designs, and that correction of deficiency through supplementation produced statistically significant pain reductions in the majority of controlled trials reviewed. For adults with arthritis who experience pain that seems disproportionate to their imaging findings, whose MRI or X-ray shows moderate changes, but whose pain experience is severe, the central sensitization mechanism we described in our knee exercises video, combined with the neural vitamin D receptor mechanism described here, suggests that vitamin D deficiency may be amplifying the pain perception that the joint pathology generates. Correcting vitamin D deficiency does not simply act on the joint, it acts on the entire pain processing system that determines how loudly the joint's distress signals are experienced. The inflammation and pain research in vitamin D is consistent on another finding worth making explicit. Vitamin D's effects on pain are most pronounced when the deficiency is most severe, and they become apparent relatively quickly within 4 to 8 weeks of initiating supplementation in deficient adults, which is faster than the structural effects on cartilage protection that require months of adequate vitamin D to fully manifest. This means that for adults who begin vitamin D supplementation and wonder whether it is working before enough time has passed to observe joint structural effects, the more immediate signal of improved pain scores provides an early indicator that the supplementation is producing its expected biological effects. The magnesium connection to vitamin D is another practically important dimension that most people supplementing vitamin D have never been told. Magnesium is a required cofactor for the enzymatic conversion of vitamin D to its active calcitriol form. Both the liver hydroxylation step and the kidney activation step require magnesium-dependent enzymes. Adults who are magnesium deficient, which includes approximately 50 to 60% of American adults, as we discussed in our arthritis bedtime video, may supplement vitamin D faithfully and yet achieve lower serum levels and lower active calcitriol availability than their dose would predict, because the conversion machinery is limited by inadequate magnesium. This explains a clinical observation that has puzzled researchers for years. Some adults on high-dose vitamin D supplementation fail to reach expected serum levels, and a significant proportion of these non-responders have unrecognized magnesium deficiency. Correcting the magnesium deficiency through the magnesium glycinate supplementation we described in our bedtime protocol dramatically improves the vitamin D response in these individuals. For adults who have been supplementing vitamin D for 3 months or more and whose retest shows inadequate improvement in serum levels despite consistent supplementation, magnesium status is the first variable to investigate before increasing the vitamin D dose. The practical synthesis of this entire video comes down to a clear sequential action plan. Step 1. Request a serum 25-hydroxyvitamin D blood test from your physician, ideally in late winter, to capture your lowest seasonal level. Step 2. Understand your result in the context of the arthritis relevant optimal range of 40 to 60 nanograms per milliliter, not simply whether you are in the laboratory's normal range. Step 3. If deficient or insufficient, begin vitamin D3 supplementation at the dose appropriate to your baseline level, taken with your most fat-containing daily meal. Step 4. Consider magnesium glycinate supplementation alongside the vitamin D to ensure the cofactor availability that vitamin D activation requires. Step 5. Retest at 3 months to confirm that your level has reached the 40 to 60 nanogram per milliliter target. Step 6. Maintain your supplementation at the dose that achieves this target, and retest annually to confirm year-round adequacy. This 6-step protocol is not complicated. It does not require expensive treatments, dietary overhauls, or lifestyle revolutions. It requires a blood test, a conversation with your physician, a daily capsule, and a follow-up appointment. And for a significant proportion of the adults with arthritis who follow it, it will produce a measurable improvement in joint pain, a reduction in the inflammatory activity that drives cartilage damage, and a joint protective biochemical environment that gives their joints the support the research shows they have been lacking. The simplest intervention in this arthritis series, the most commonly missing piece of the management puzzle, and the one that starts with a question only you can ask: what is my vitamin D level? Ask it, find out, act on the answer. If this video gave you the clarity and the specific guidance you needed about vitamin D and your arthritis, please support this channel. Hit the like button right now. Subscribe if you have not already. Share this video with someone who is managing arthritis and has never been told to check their vitamin D level. And leave a comment below. Tell us whether you have been tested, what your level was, and whether you are going to ask your doctor about this at your next appointment. We read every single comment, and your story matters to every other person in this community who is managing the same condition. Thank you so much for watching. See you in the next one.